Thank you very much, Mr. Chairman. This morning we will have some discussion of the interesting, difficult cases. We'll kick off with Professor Chang Shu. Professor Shu is a director of the Department of Vascular Surgery at the National Center for Cardiovascular Disease in Beijing, China. And actually, Professor Shu also is a director of the Department of Vascular Surgery at the second Xiangya Hospital at the Central South University. He's a busy person, so we are lucky this morning to have Professor Chu to come here and share with us his expertise. And Professor Chu will talk to us about TEVAR Zone 2, how I do it. Professor Chu, please.
Okay. Thank you, Professor Bong. Professor Chen Pong, dear friends, so good morning. It's my great pleasure to be here. So today I'd like to talk about some clinical cases, the Zone 2, how I do it. So the current solutions, just according to the guidelines, so when we find it, the LSA is very important. So it's a must for us to preserve it. Use different kind of method. So nowadays in China, so most of the patients will be preserved the LSA. It's totally different from 10 years ago. 10 years ago, we published lots of papers talking about to sacrifice the LSA. But nowadays, we preserve it. So there's some data from the Fuai Hospital. So you may find it among these cases. Nearly 35% are involved with the aortic arch. So that's the data from Fuai Hospital. So I presented in link meeting. So you may find it. Many patients will be done by fenestration. So to some special cases, we still emphasize. For example, like this gentleman is aged enough. Also, the aorta and the branch vessels are not so good. So we still prefer chimney to do it. Not just only according to the guidance, but we have to just according to the different situation of the patients. So you may find it. To the very special cases, especially in emergency, the chimney combined with a snorkel is still very useful. So that's a result. You may find it. Not only the instant result, but also the long-term result is perfect. So we do emphasize you select the right standing graft and the right branch standing graft. For example, in most of our cases, we perform chimney and snorkel with a Medtronic device, and elongate and left carotid. We select fluency, about the snorkel to LSA, we select a gore system. For example, such kind of cases, in an emergency, full of lots of thrombosis, also the patient suffered from the stroke and severe chest pain. Then he come to our emergency room, then we do it very quickly just by chimney. So, the left carotid and the left subclavian snorkel, we finish all the procedure just within 1.5 hours. Let me talk about the fenestration technique. We do know that the first fenestration is described by Park in 1996. So in China, now we have two methods. One method is in vitro, another one is in situ. We emphasize, we select the different device to perform fenestration on table. Finally, we find if we have the self-mark imaging guiding standing graft, then it's much convenient for us to do it. So we compare with a different kind of standing graft. The first standing graft I had ever used to make chimney, make fan switching is relay. Also, I try with a gauge instrument, the Medtronic, the Coke. Finally, you find it. The Acuna contained an 8 in the big cave with the tip, and 0 on the small cave, and the supporting bar on the big cave. So it's more convenient for you to make fan switching much quickly and easy. So we do it very freely, only if the aortic arch is severe angulation or tortuosity. To the most flexible aortic arch, you can perform on-table fan switching very freely and get a very good result. Also, the operation time for one branch vessel, just half an hour. Then you can perform with the on-table fan switching for 2 branch vessels. For example, this one, you can do it. Just make 2 fan switching and to perform the whole procedure very quickly and finish the good case. So also, when we find it, such kind of procedure is applied in different kind of situation. For example, this one is similar like the former one we perform chimney, but he's not in an emergency. Then we prepare everything well. We perform fan switching to finish the whole procedure also within 1.5 hours. So, to perform chimney, still there's some tips. First, you have to choose the right patient for you to do this procedure. Also, we have to have a very well evaluation of the aortic arch anatomy. It's very important. The third one, the angle of the angiography should go straight to the aortic arch. So usually we select the left side about 14 to 15 degrees. So that's very important. Also, we avoid to situ the mark for such a long time. So we select the self-image marked standing graft. That's some early times we published paper before. But nowadays, for my personal experience, the on-table fan switching already more than 700. So we'd like to say more than 99% of the cases will be done freely. Another one we emphasize is the in situ fan switching. In situ fan switching, we prefer use a puncture needle. The puncture needle as compared with a laser system, so we may find it. The laser system is much easy to cause the stroke, but the puncture needle is not so easy. Usually, use this device is safe enough. Just like the case we have done yesterday, we have 2 methods. The first one, we use a bonding puncture system. So it's invented in Fuai Hospital. Another one is the balloon contained the puncture needle, also combined with another sift, the full star sift. So these 2 methods are very well for you to do it. We also invent the special device, the C-skirt system, including the big standing graft. So more space for the aortic arch in the big cave. Less stand. So it's much easier for you to make fan switching. But the small curve, more stand, is more flexible to run across the aortic arch. Also the tip of the bell stand will change a lot. The tip of the bell stand will not puncture to the aortic wall. The tip of this one is a bit flexible, then you can do it to prevent the puncture. Also, you may find the front stent graft we select with a skirt. So the whole system, we use it. And in China, we finish the multi-center investigation. There are 120 cases are involved. Then the result is perfect. So there's some cases we have done by such kind of device, you may find it to perform this technique is very easy for you to do it. We emphasize during operation, you have to change the machine the angle to focus on the branch vessel. So that's also, we use this one to perform the in situ fenestration, a low matter dissection or aneurysm. So we perform the procedure is very freely. You may also find it, the operation time is not too much. So we need to perform this procedure sequence by sequence. As you puncture needle pass through, then you can use a small balloon to balloon it. Then you change the big balloon till 6 millimeter. Then you can deploy the cover stent. So this one we emphasize, sometimes you have to use a shift to pass through the fenestration area, because maybe if you never use the skirt system, for example, you use other kind of device, including especially for the gore system, we'd ever try it because the gore system is EPTFE, but he has more stent on the big cave. So you will be very careful. You have to pass through the shift before you deploy the standing graft. So you may find it, the dissection cases, you perform in situ fenestration, it's very free for you to do it, and you can get a very, very good result. So among the 120 cases, multi-center investigation, so we may find it, the result, the endo leak is only 2.1. Then no branch vessel occluded, and no periplexy and no stroke. So this one is a demonstration with a binding puncture system. So you may find it as we pass through, then you can deploy the standing graft. So we early published the paper in 2019. So we may find it, the midterm result is very nice. We can also combine with the in vitro and in situ fenestration together, just according to the different anatomy of the patients. If the disease area is very near to the LSA, also the left carotid is not far away from the LSA. So we select the left carotid on table fenestration and LSA in situ fenestration, just in order to prevent the endo leak. So this is a combination we perform to the special cases, then you can get a very good result. Also, the operation time not so long. So there's a branch system already in the market we had ever used. We can perform with this device very freely. It's a caster. So in different kind of situation, including the PAU, also including the CD aneurysm, this one, the best advantage, so it's a whole body. The branch system, the branch vessel system and the big standing graft combined together. The best disadvantage, so we have to pay much attention to the small curve. The small curve sometimes uses device, it will drop down to the aneurysm or the disease area. So that's a case we have done with a caster. Also, with a dissection, we can do it. But we emphasize this device, you use it, maybe you have to spend more time. As compared with on-table fenestration, it will be double, because you have to dissect the breccia, then deploy the caster to finish the whole procedure. So, as compared with a different kind of device, we emphasize to aortic arch. If we can do on-table fenestration first, then we will select on-table. If on-table is not safe enough to prevent endo leak, then we will select the in situ. Then lastly, we select our caster, the branch vessel. Also in China, we will emphasize the hybrid procedure because we are surgeons. So To the zone 2, still we can use a hybrid procedure. For example, like such kind of cases, you can also perform the bypass. To the surgeons, simple and easy, but the best disadvantage, you have to spend more time. But anyway, to the very special cases, it's also a very good method. So we emphasize to the zone 2, we can select the endo procedure, including the chimney, fenestration, including the in situ or in vitro, also the bronchial graft or hybrid procedures. Okay, thank you so much. Thank you.
Thank you very much, Professor Shu, for the kickoff this morning, showing a lot of cases in Zone 2 and many options. Dr. Pramod, any comments, any question?
Yeah, thank you.
Thank you. Very interesting in the technology. And I have the question that you have many kinds of method to do, like that you use the in situ fenestration and do like the C-skirt stent. So how can you choose which one that you will use just in situ or which one you use the C-skirt stent?
Thank you. Thank you, Professor Pramod. So, in what kind of situation we should select in situ fenestration, and in what kind of situation we should select on table? So we emphasize the first one, if the whole aortic arch, no angulation, no severe angulation, then also the disease area to the fenestration branch vessel exists at least 1.5 centimeters, then I prefer on table. If the fenestration area is less than 1.5, even 1 point to the aortic dissection, 1.5 centimeters to the annular, but 1 centimeter is to the aortic dissection. You know, aortic dissection is not the same situation as compared with annular. It's easy for you to prevent endoleak. You will perform fenestration. If the disease area is within 1.5 centimeter, so we prefer with in situ fenestration. But in situ fenestration, if you use a special device, for example, the puncture needle, you select the foot star combined with a bolon puncture needle. If the LSA is severe angulation, never do it. You cannot pass through. In this time, you have to select our invent device, the bending puncture system. Just like I show you, the bending puncture system is very soft. Only the tip is stiff, but the delivery system is very soft. So if the severe angulation of the LSA, you may select the bending puncture system. So that's my personal experience. Thank you.
What about the chimney and the hybrid? When to use it? What is your suggestion?
Good, very good. The hybrid situation is that the patient's anatomy is not so good for you to perform fenestration or chimney. Sometimes severe calcify or exist lots of thrombosis. You cannot make too much procedures inside the lumen, inside the aorta and inside the branch vessels. This time, I suppose, maybe a bypass is more safe. So, chimney we emphasize to the emergency case and to the very aged people, especially people sometimes even cannot bear the general anesthesia. So we can do local anesthesia to treat it. So very quickly and very safe. But we still were worrying about how about the endoleak. So as we select the long gate, today I didn't talk too much about long gate. In the long time I will talk about it. Also, the new 3 branch vessel system. Thank you, Professor Bo. Thank you.
Well, thank you very much, Professor Shu.
Thank you.
For a nice talk this morning. Thank you.